have with us Dr. Ashish Kumar. Dr. Ashish is going to enlighten our knowledge on non-alcoholic fatty liver disease in non-obese people, new data. Dr. Ashish is a professor and senior consultant of gastroenterology and hepatology at Sir Gangaram Hospital, New Delhi. Over to you, sir.
So, good morning, ladies and gentlemen. At the outset, I would like to thank Dr. Anup Mishra, Dr. Ritesh Gupta for inviting me to this prestigious Ahuja Bajaj Symposium. So, switching gear from kidney to liver now. So, I would try to cover not only non-obese NAFLD, I'll also try to briefly discuss about the recent nomenclature change in for NAFLD, as well as what are the management issues. So why did we change the name of NAFLD? Now it is called as MASLD, Metabolic Dysfunction Associated Steatotic Liver Disease. So the problems with NAFLD nomenclature was that whenever the patient who comes with diagnosis of fatty liver, carrying a report of ultrasound having fatty liver, the first question any doctor would ask, do you take significant amount of alcohol? That means for males more than 20 gram of alcohol per day, and for females more than 30 grams per day. So the first question you would ask, are you taking alcohol significant amount? If the patient says no, then you would then label him as non-alcoholic fatty liver disease. But still you would, the patient would feel stigmatized, because now you are calling him that you have a disease of liver which is similar to alcoholics, and so it is stigmatizing for the patient. And giving a non-alcoholic label to a patient, maybe a pediatric patient or a female who has never taken alcohol, is also again stigmatizing. And because the fatty liver is now synonymous with being a person who has become fat, so it was body shaming. And you have this disease because you are fat, so you are having fatty liver disease, so you must lose weight. So all this was stigmatizing. But if the patient was taking significant amount of alcohol, again this was stigmatizing for that patient also. Now we are focusing entirely on alcohol, that then you have a liver disease because of alcohol, and you have to cut down alcohol because you are alcoholic, and then you are ignoring his diabetes mellitus, you're ignoring his metabolic syndrome, you're ignoring his obesity, and all these were ignored. So these were the problems with the nomenclature as well as the criteria of NAFLD. So there was an effort to change the nomenclature from NAFLD to MAFLD. It was changed in 2020, but it was again met with a lot of resistance and disagreements. And finally, in 2023, with the multi-society consensus guidelines, the nomenclature is changed to metabolic dysfunction associated steatotic liver disease, which is accepted by most societies now. So this was published as recently as June 2023 in multiple journals, including Journal of Hepatology. So now there is a paradigm shift. The patient, when he comes, he's carrying a report of fatty liver, you will label him as steatotic liver disease. So you'll remove the word fat from him and be more scientific in calling him steatotic liver disease. And then you would first ask about metabolic abnormalities. So there are adult criteria of BMI, obesity, type 2 diabetes, pre-diabetes, blood pressure, triglyceride, LDL. So you will check all these first. And then if the patient says that he has metabolic abnormalities, then next question then you would ask whether he is taking significant amount of concomitant alcohol use. If he says no, then you will label him as MASLD. If he is taking alcohol as well as has metabolic abnormalities, then you will call him MET-ALD. That means metabolic associated steatotic liver disease along with alcoholic liver disease. But if the patient does not have any metabolic conditions as mentioned in the criteria, he is taking significant alcohol, then you will label him ALD. And if he is not even taking alcohol, then you will label him as cryptogenic steatotic liver disease, or you will check for other drugs which can cause steatotic liver disease. So using this terminology change is more pragmatic, and it now focuses on metabolic aspects of liver disease. So what is the treatment for patients with NAFLD? So as per the Indian guidelines, as published by NAFLD, the Indian National Association for Study of Liver, since the NAFLD is a treatment of lifestyle, so it revolves in controlling the lifestyle risk factors, and since most of the patients are overweight or obese, so we have to control their weight. So weight loss with a target of 7 to 10% is the recommended treatment for all NAFLD patients. So what will be the effect of weight loss? And we have seen in any of the NAFLD presentations, we have seen this slide, that if you are able to reduce your weight by more than 3%, there is a reduction in steatosis. If you are able to reduce weight by more than 5%, there is reduction in inflammation of the liver. If you are able to reduce more than 7%, then NASH is reduced, and if you are able to reduce weight by more than 10%, even fibrosis component can be reduced. But since my lecture is on patients of non-obese NAFLD, so if the patient who comes with non-obese NAFLD, does he still require weight reduction? So let us understand what is NAFLD. If I would be giving this talk in Western countries, I would call those patients whose BMI is more than 30 as obese NAFLD, and those with less than 30 as non-obese NAFLD. But with the guidelines given by Dr. Anup Mishra way back in 2009, now Indian criteria or the Asian criteria of definition of overweight and obesity has changed, and the cutoff is now 23 for overweight and 25 for obesity. So for Indian patients, to call it non-obese NAFLD, we have to have BMI less than 25, but still these patients are overweight. So a patient with a normal weight NAFLD would be those who are having BMI of less than 23. But still, is BMI that important? So many studies from Dr. Vikram's group, Dr. Anup Mishra was part of that study, have shown that it is waist circumference which is much more important than BMI, and it is patients having higher waist circumference have 11 to 12 times more chances of developing metabolic syndrome and other metabolic related diseases. And so waist circumference of 90 centimeter in male and 80 centimeter in female is the cutoff given by most of the consensus. So even in patients with normal weight and BMI or normal weight NAFLD, you would again look at the waist circumference, and only if the waist circumference is less than 90 for males and 80 for females, then you label him as lean NAFLD. Otherwise, all these patients, even if the weight is normal, even if the BMI is less than 23, most of these patients would be having abdominal obesity and insulin resistance, and which is correlates with the fatty liver disease. So in Indian patients, in India, abdominal obesity is very common. This is again study from Dr. Anup Mishra's group, where he reviewed the literature in South Asian countries, and in India, patients across the population, 60% of people have abdominal obesity as measured by waist circumference. And it starts right in the childhood, right from the age of 10 to 12 years, the abdominal obesity with the black bar, keeps on increasing, and by the time the person reaches the adulthood, he has significant abdominal obesity. So what is the prevalence of NAFLD in India? As per the latest systematic review and meta-analysis published from the AIMS group, the prevalence of NAFLD in India is close to 40%, and it mirrors the high prevalence of abdominal obesity in the population of India. And what is the phenotype of NAFLD patient? If we look, this is again study from Dr. Anup Mishra. These patients with NAFLD will have high body fat, they have high body mass index, they have high waist circumference, and apart from that, they have other phenotype, double chin, buffalo hump, they have high fasting insulin, high CRP levels, high blood pressure, high insulin resistance. So what determines the hepatic outcome in patients with NAFLD, and how should we evaluate this? So NAFLD has basically three components. One is steatosis, that means increased fat in the liver. It has got inflammation, increased inflammation, and the fibrosis. So if we look at the natural history of NAFLD, patients with NAFLD, about 25% of them will progress to have NASH. NASH is the patient who have fat plus there is inflammation in the liver and they start to have fibrosis. And of the patients of NASH, 25% will eventually, over the period of 1 to 2 decades, will progress to cirrhosis, where they have now significant fibrosis, significant scarring of the liver, and then some of them may go on to develop liver cancer as well, hepatocellular carcinoma. So the driver of hepatic outcome is not inflammation, it is the liver fibrosis which determines the outcome of patients with NAFLD. So as per the INASL guidelines on management of NAFLD, the most important aspect you would check in a patient of fatty liver is their fibroscan or their liver stiffness values. And the cutoff given for significant liver fibrosis is 8.2 kilopascals. If the patient is having liver fibrosis, liver stiffness more than 8.2, you would, these are the patients who are at higher risk of further progression. And apart from fibroscan, you can also do FIB4 and APRI level, but I would prefer doing a fibroscan because it is the most validated test for liver fibrosis. So what is the management algorithm for patients with NAFLD? So any patient with NAFLD who comes to your clinic, you will do anthropometric measurement, you will check his BMI, waist circumference, sarcopenia, etc. You will do his dietary assessment, either using 3-day recall or 7-day recall, to understand what is the calories he's consuming, what is the protein content, what is the sugar content he's taking, and you will do his clinical assessment in terms of fibroscan, liver fibrosis assessment, liver function and comorbidities. And then you will recommend physical activity in all these patients. So physical activity in form of exercise, at least 200 minutes per week of exercise, moderate intensity exercise, or also you will encourage his non-exercise intermittent activity thermogenesis, which means you will encourage him to do physical activities. So if he has to go out anywhere, it is better to walk rather than take transport. If he has to climb stairs, instead of he should not take a lift, he should climb stairs. So that is the increase in physical activity, and also exercise and combine the resistance exercise who cannot do aerobic exercise. And then you will target his weight reduction. So any patient who has overweight, who has high waist circumference, you would ask him to reduce weight by 5 to 7% and at least 10% weight reduction if they have significant fibrosis. And only on those patients who have lean NAFLD, that means their waist circumference is also low, his BMI is also low, then you may ask him to maintain that healthy weight. But even in these patients, if the LSM value or the fibroscan values are high, then again you would advise a modest reduction and 3 to 5% of weight reduction. And then there would be, you would advise him change in dietary composition. What about that drug therapy for NASH? The drugs for NAFLD are two types, those who target NASH and those who target weight reduction. There are multiple drugs like GLP-1 agonists, SGLT2 inhibitors, PPR agonists, FXR agonists. But let me give a disclaimer, none of these drugs are FDA approved as specific therapy for NASH. Most of these like GLP and SGLT2 are used in diabetic population in association with fatty liver disease, but none of them are FDA approved for NASH. In India, saroglitazar is approved by DCGI for use in NASH. There is good data to suggest GLP agonist for treatment in NASH population, and there are trials which have been published in NEJM. And they have shown that they are able to reduce the inflammatory component, but none of these drugs have been able to reduce the fibrosis in NASH. And there's also oral semaglutide has been shown to be reducing the ALT as well as steatosis in these patients. What about SGLT2 inhibitors? There again good data to show that these are able to reduce the ALT levels. These are able to reduce fibrosis in only a minority of population, and they are able to reduce the liver fat contents. And there's been trial on dapagliflozin from India as well, that it does reduce the APRI score, does reduce the liver steatosis. What about PPR agonists? There are multiple PPR agonists which have been used, pioglitazone, saraglitazar. There are multiple studies of them. Now saraglitazar is now approved in India, and there has been trials which have shown that they reduce the ALT levels.
Dr. Ashish, please try to wrap up.
Last 1 minute. And this trial was done in our center where I was part of that, and that we showed that it does reduce liver fibrosis to a certain extent in those patients who are able to reduce their weight. And there has been good data. So I'll skip on all this and come to the concluding slides. So to summarize, the new nomenclature of NAFLD to MASLD is more pragmatic and should be adopted by majority of you managing these patients. Even in patients with non-obese NAFLD, the majority have abdominal obesity, and so weight loss, weight reduction remains the mainstay of treatment. Even in non-obese NAFLD, the outcome of NAFLD is determined by fibrosis, and it must be evaluated using fibroscan in all these patients. And the drug therapy for NASH is still evolving. There's some data to suggest GLP-1 agonist and SGLT2 inhibitors. They are good option in patients who have NASH in presence of type 2 diabetes. And saraglitazar has been approved for treatment of NASH even in non-diabetic population. Thank you for your patience.
Very insightful presentation, Dr. Ashish. Thank you.